Majid from MedStudent Help. This is a follow-up video of the previous one. So here we're going to continue talking about how to approach hypercalcemia. In the previous video, we explained how the calcium is regulated in our body and how does the parathyroid hormone work. And we ended saying that if we find a patient with a hypercalcemia, the first thing we do is to measure the parathyroid hormone level in the serum. If the parathyroid hormone level in the serum is elevated, this leaves us with two differential diagnoses: the primary hyperparathyroidism and familial hypocalciuric hypercalcemia. Here I'm going to explain the difference between these two diseases. Now, how can we differentiate if the patient has the first or the second, right? Now, a primary hyperparathyroidism means that we have a parathyroid gland that is hyperactive. Although we have a very high serum calcium, it is still not suppressing the parathyroid hormone, which means that the negative feedback is not working because there's a problem with the parathyroid gland. But the problem is not in the receptor. It is not the receptor that is sensing how much calcium is there in the serum, but because we have something pathological in the parathyroid gland producing more parathyroid hormone regardless of the negative feedback, which are adenomas or hyperplasias or cancer. And we said that it can also be a part of the MEN syndrome, right? Now, so the thing is, in primary hyperparathyroidism, due to the very high parathyroid hormone leading to the very high serum calcium, what happens next in these patients is that the kidney starts excreting the excess calcium. The excess calcium, right? So in a primary hyperparathyroidism, if we measure the 24-hour calcium excretion, we would find that it would be more than 250 milligram, right? So we collect the urine of this patient for 24 hours, and then we measure the calcium level in it. If it is more than 250 milligram, this is diagnostic for primary hyperparathyroidism. But if we don't have time to wait for 24 hours, then what we can do is measure the urine calcium to creatinine ratio. If this ratio is more than 0.02, this is also diagnostic for primary hyperparathyroidism. This is how we differentiate primary hyperparathyroidism from familial hypocalciuric hypercalcemia. So in the name, that this disease is carried in the genetic material, and then there is a low calcium level in the urine, but there is a high calcium level in the serum. Now, the pathophysiology of this disease is a defect in the calcium receptor of the parathyroid gland. So we know that the parathyroid gland has this receptor which is responsible for sensing how much calcium do we have in the serum. And when there is a high serum calcium, right, and the receptor sense this high calcium level, it suppresses the parathyroid gland. But in case of familial hypocalciuric hypercalcemia, this receptor is defective. So the parathyroid gland would continue producing parathyroid hormone regardless of the calcium level in the serum. But the characteristic thing is that although there is a very high serum calcium, right, there's no increase in the calcium excretion in the kidney. So this is not present in case of the present in case of the familial hypocalciuric hypercalcemia. Therefore, if we measure the 24-hour calcium excretion in the familial hypocalciuric hypercalcemia, it would be less than 100 milligram. And if we didn't wait for 24 hours and we just measured the urine calcium to creatinine ratio, it would be lower than 0.02. So that's how we differentiate between primary hyperparathyroidism and familial hypocalciuric hypercalcemia. Okay, so let's say that a patient was diagnosed with the primary hyperparathyroidism. What would you do next? What you should do is a bone scan, right? Because we know that if the patient has a very high parathyroid hormone, this means that we are inducing calcium resorption from the bone. So resorbing the calcium from the bone makes the bones weak, and this might cause osteoporosis in these patients. So we do bone scan looking for osteoporosis. Okay, osteoporosis. Now, the next thing is that we need to know where exactly is the hyperfunctioning parathyroid. As we know that we have the parathyroid glands located posteriorly to the thyroid gland. Okay, so which one of them is the active one? Which one of them is the one that has adenoma or cancer? Or do all of them have hyperplasia? Therefore, what we need to do is a test called systemibiscan. Systemibiscan. So this scan can actually figure out which parathyroid gland is the active one and it is causing the problem. After that, the preferred treatment for primary hyperparathyroidism is surgery. But not every patient is actually a good candidate for surgery. Or some people just refuse the surgery and they just don't want to go through that hell, right? So what should we do for these patients? We should prescribe them bisphosphonate. Bisphosphonate. Why? Because as we just said, that this primary hyperparathyroidism is causing osteoporosis. So just to inhibit that, we can give bisphosphonate. We shouldn't give calcium carbonate, right? We wouldn't give calcium carbonate because these patients have so much calcium already. Their problem is not calcium. We shouldn't give vitamin D either because they do have calcium in their body. But we need to deposit the calcium back into the bone, which is the function of bisphosphonate, right? Okay, so now let's move to the other part of the chart here. And let's say that a patient who has hypercalcemia and presenting with constipation, abdominal pain, and renal stones, and some bone pain, has hypercalcemia. And then when we measured the parathyroid hormone, we found that the parathyroid hormone is actually low, but the calcium level is still high. So what is the differential diagnosis? As we explained in the previous video, we said that there are 4 differential diagnoses in this case, that it can be a malignancy producing the parathyroid hormone related peptide, or a malignancy producing an endogenous vitamin D, or intoxication, right? And it can be also the use of calcium carbonate. How can we differentiate between these? To differentiate, what it makes sense is that we can measure the parathyroid hormone related peptide. If it is high, then it is diagnostic. The second thing is that in vitamin D intoxication, regardless if it is exogenous or endogenous, what we should look for is the phosphate level. Now, what do you expect the phosphate level to be if the patient is consuming so much vitamin D? The phosphate level in these patients would be high, right? Because as we said, that vitamin D is working on the gut, increasing the calcium and phosphate absorption. But when it was a problem with the parathyroid hormone, when it acts on the kidney, it increases the calcium reabsorption, but it increases the phosphate excretion, right? So if there was a normal level of parathyroid hormone and a normal level of vitamin D, the phosphate level would stay normal. But when there is imbalance, which is in this case a low parathyroid hormone and a high vitamin D, this is going to lead to a high phosphate absorption. So when we do the CBC, we should look for a high phosphate level, right? Okay. Now, milk-alkali syndrome, what does it mean? So this is a patient who refused to use bisphosphonate and decided to use calcium carbonate from the nearby store, right? Now, this patient is consuming this supplement, which is actually elevating their serum calcium level. But not only that, it is also increasing the alkalinity of their serum, because these supplements have some sort of absorbable alkali that can actually lead to metabolic alkalosis. Okay, so what happens when this patient consumes these supplements, what can happen is that the high serum calcium together with metabolic alkalosis can lead to renal artery vasoconstriction, right? Constriction. When this happens, this is going to decrease the GFR. When the GFR is low, what happens next is a decrease in the water and sodium excretion, right? When this happens, there is going to be an elevation of the bicarbonate reabsorption, which is going to further deteriorate the metabolic alkalosis. So, if we found that a patient has a hypercalcemia, we should check the phosphate level. If it is high, then it is related to vitamin D. If it is not high, then it is something else. We looked for parathyroid hormone-related peptide, and it is not that. But we noticed that this patient who has a hypercalcemia also has metabolic alkalosis, right? Together with these two, these patients usually also have the acute kidney injury. Why is that? Because we said that they are inducing a renal artery vasoconstriction. So a combination of these, together of course with low parathyroid hormone, because it is suppressed with the negative feedback, this should actually ring a bell for Milk-alkali syndrome. Okay? So that's it about the approach for hypercalcemia. In the next video, I'm going to try to cover hypocalcemia and the pathologies of the parathyroid gland. Thank you so much for watching.